So we'll move on to our third speaker. So we have Professor Mikkel BRABRAND. He's a clinical associate professor of the University of Southern Denmark and the research director of the Department of Emergency Medicine of the Hospital of Southwest Jutland. He's also an adjunct associate professor of our unit. So please begin, Professor BRABRAND.
Thank you so much. It's an honor to be here, and I'm very thankful for the opportunity to speak. I've been asked to talk about the future of early warning scores in emergency medicine, and that's something that's very dear to me, so I hope I can provide some insight. I have no conflict of interest to report. Now, we can use early warning scores for quite a few reasons, and one of them is, of course, to find the sick patient. I believe that would be our main objective. Now, we can also use it maybe to find the well patient or the non-sick patient and maybe handle them accordingly. Another reason could be to find the needle in the haystack, or basically to monitor our patients and see if we can find the ones that are deteriorating or maybe even improving. And finally, we can always do it to keep the bureaucracy happy, because we have so many documentation requirements these days that we need to keep on top of them. If we start out with the, for me at least, less important one, the bureaucracy. This is not a cheap exercise. Measuring and documenting vital signs takes about 2.5 minutes per patient for a nurse. And that is quite some time if you have enough patients on your ward. At least in our unit, the university hospital I work at, we only have 2 nurses per ward at night. And if they have to spend 2.5 minutes doing vital signs, one of them will basically spend most of their watch just looking at vital signs and measuring them. Of course, then they can tick off the boxes and say, we've done it, and the checklists are happy. But this is expensive, and maybe we could use their time a little bit better. So what about finding a sick patient? Well, how many actually do deteriorate? We had a PhD student look into our unit. We have an emergency department covering about, well, it depends on how you calculate, between 250 and 1.2 million, depending on what the problem is. And we see about 100 medical patients a day and about 100 orthopedics and a few others, neurology and general surgery. And we found that during the first 4 to 48 hours, we had 1.5 of these patients had an event, and this is out of 38,000 patients. Now, of the 1.5%, we then looked through the medical records to see if this was unexpected or expected. And 65% of those, it was expected. We'd seen it coming, we had prepared, the patient hadn't deteriorated yet, but we were waiting for it to happen. And we had a contingency plan. For about 23%, the event, when we looked into the records again, were unexpected, but you could actually see warning signs. So the staff should probably have seen it coming, at least in retrospect. But 12% of these deteriorations came completely unexpected and with no warning. So basically, they came out of the blue. Now, if we transfer that to how many patients we see, that would be 1.2 out of 1,000 patients. In other words, about once every 1.5 weeks or so for us, we'd have a patient deteriorate. Now, we work 37 hours a week in Denmark. So most of our staff would only be in this situation rarely, and there could be months between seeing an unexpected deterioration of a patient. So we need to find a way to find these patients. So what we do is we use early warning scores or our triage system, and basically it all comes down to measuring a lot of vital signs. There are many you can measure, and I think these are probably the most routine: blood pressure, heart rate, respiratory rate, temperature, and oxygen saturation. Now, we've started looking into vital signs because we've come to the conclusion that it might not be one size fits all. It really depends on how well you are, what your functional capacity or your reserve physical capacity is, how well you tolerate abnormal vital signs. And therefore, another of our PhD students is trying to look into the effect of age and vital signs. He's a geriatrician by training. but has an interest in emergency medicine, and we're therefore doing a combined project. Now, what we did was we looked at 15,000 patients from 4 EDs in Denmark, a mixture of every possible presenting complaint you could come up with, not minor trauma though, but still enough for them to have their vital signs measured. And then we stratified this into 4 age groups. So the lowest quartile had a mean age of 33. The second had a 56-year-old's mean age, then 71, and then 84. We do not get to be as old as you do in Hong Kong and Denmark. We live very unhealthy, unfortunately. But as you can see here on this plot, which is basically a cubic spline plot of the vital sign and the 4 age groups. On the x-axis, you have the systolic blood pressure, and on the y-axis, you have the mortality for the 7-day mortality. The dotted lines are the mean mortality for that age group, and the numbers are where they cross the plot. If you look at the 2 bottom ones, the green and the red ones, these are the 2 young age quartiles. And as you can see, they hardly have any increase in mortality with abnormal vital signs. But as you age, you parallel shift your risk up. So just being older, of course, carries a higher risk of mortality when you're admitted. And even though you parallel shift up your risk, you can also see that at the extremes, you are less tolerant to abnormal vital signs. Here's systolic blood pressure. So you're at a higher risk if you're old, and you cannot tolerate the abnormalities quite as well. Now, even though this is the case, the cutoffs are basically the same. So somewhere the body still handles this rationally. Now, if we look into heart rate, we see completely the same pattern. The young ones have a very low mortality, and then again, we parallel shift up with age, keeping the same cutoff, but again, less tolerant capacity for abnormal vital signs. Respiratory rate, this is a J-shaped curve. Bradypnea and tachypnea are dangerous. And again, same parallel shift, same reduced tolerance. And of course, temperature. Now, what was interesting to me is in this population, the old actually tolerate both hypo and hypothermia not well. And usually here, at least, we say that if you have a fever, we've got something to work with. But if you're hypothermic, you're in trouble. And apparently, this is not a one-size-fits-all for the old, at least not these 15,000. And then, of course, we have saturation. For this, unfortunately, I do not have the amount of supplementary oxygen given. So this is basically just the data raw as it is, but it's completely the same pattern I've shown you the other times. Now, once we've measured all our vital signs, we can then calculate an early warning score. Now, I've called this slide the early warning score, and of course, that's not the complete truth. There are quite a few early warning scores out there. I'm familiar with about 100 different early warning scores, and they all have different components and all have different cutoffs for assigning points for levels of abnormalities of vital signs. But in my opinion, the best validated, the best tested score is the early warning score from the UK, and that's why I will refer to that from here on. And we're just now implementing the news to the new version of the news at my region where I work for all the hospitals we have. Now, for the news, you get your vital signs, respiratory rate, oxygen saturation, and so forth. And then you use your measurements and assign a score that could be between 0 and 3, depending on the level of abnormality. You then add up all the scores and you come up with a new score. This was developed in Portsmouth by Gary Smith and Dave Prytek, and they've spent a lot of time looking at different early warning scores, and this is the final one they've come up with and the best working. Now, does it work? Well, it actually does. On the right-hand side, you can see a bar graph and a lot of dots, and the black dots are the combined endpoint of cardiac arrest, ICU admission, or death within 24 hours after the vital sign has been measured. And as you can see, the risk of deterioration or having a poor outcome goes up almost exponentially with your news value. And there have been a lot of studies on this, and news is very good at predicting poor outcome within 24 hours. So it's a very good suggestion of an early warning score to use. Now, we then thought, let's test if it works with us. Because in many hospitals, well, if you read the news material, you have to implement it as it is, otherwise you cannot refer to it as news. And therefore, we wanted to figure out if we can use it. Now, if we were to use it, we should have a highest risk comparable to a score of 3 if we have patients with a systolic blood pressure that would score 3, and again, same for temperature and oxygen and so forth. And actually, what we found when we did this was interesting. This can be a bit difficult to understand, but these are the fits for news variables in our population. Now, if we have a systolic blood pressure, actually a news score of 1 would be a 1.2 for us. A score of 2 would be a 2.4 for us. And then score 3 would actually be just a 2.8 in the news. So systolic blood pressure is not completely well fitted for our population, whereas the AFPU, or the level of consciousness, is perfectly fitted. But as you can see, if you look at supplementary oxygen, if you have supplementary oxygen, you have a score of 2. That would actually just be about a score of 1 in risk for us. And the heart rate or the pulse is completely off in our setting. So we basically have very, very little increased risk with an abnormal pulse. And therefore, we might want to have to recalibrate news for us to use. Now, I have to mention that when we did this, we used 7-day mortality and not the 24-hour mortality that news used. And that's simply out of a lack of endpoints in our population. Now, another way of looking at this is what's called calibration. When we talk about scores like this, we talk about discriminatory power, or the ability to find the sick patient, and then the calibration, or the ability in the precision of that assessment. These are calibration plots for the same 15,000 patients in age groups. So you have the youngest on the left, at least on my screen. In the middle, you have the middle-aged, or it's not, I'm sure my friends would call it that, but 65 to 85. And on the right-hand side, you have the 85 plus. As you can see on the calibration plot on the left, you have a very, very thin gray line. And I'm sorry, I couldn't get it to be more clear here, but you have a thin gray line here. That would be the perfect fit. The black line here is then what actually happens with the news. And here we have a low news, and then as news increases, we deviate from the gray line, meaning we have an over prediction of patients with a high news in the young population. In the middle group, it's a perfect fit. It goes almost along the line all the way up, and it's very well in the middle group. And that's, luckily for us at least, the majority of our patients. Now, for the old, it's okay if you have a low news, but as soon as your news goes above 5 or 6, we deviate, and we're going to have a lot of false alarms, because it's going to over triage our patients. So we need to adjust this if we were to use it. Otherwise, our nurses would go crazy with all the false alarms. Well, does this actually help? When you do an early warning score, you also have to have something to correct it. And usually people implement these medical emergency teams or rapid response teams, where you identify a patient being at risk using the early warning score, and then you call the team, usually from the ICU, to stabilize the patient. There have been 2 large multi-center randomized controlled trials of this, and neither of them were able to show an effect. Now, there can be many, many, many reasons for this, and I believe the main reason is that these studies are underpowered. It's a daunting task to do a study like this, and it's difficult to do to the size you need with the complexity of a randomized controlled trials. But if you go into this, it's actually very interesting, because what triggered the rapid response team or the medical emergency team, and in 25% of the cases, it wasn't the early warning score, it was a nurse worried assessment. So basically, the staff was worried about the patient and then alerted the response team, and not just the vital signs. So what about the well? Can we use the early warning scores to find the well patient or the non-sick patient? And to some degree, you can. This is a study of 3 different scores, and please disregard the top one. But the MUSE and the NEWS. The MUSE is the modified early warning score, and that's heavily used in the US, while NEWS is very European focused. And as you can see, if you look at bad outcome within 24 hours, as you increase your score from a cutoff of 1, 2, 3, 4, 5, you decrease your sensitivity and you increase your specificity. And that goes both for the MUSE and the NEWS. So basically, if you have a very low score, you're going to pick up most of the patients that are deteriorating, but you're going to have a lot of false alarms. And if you keep the score very high, you're not going to have very many false alarms, but you're not going to find all the patients. So it's not very good per se at finding well patients. And one of the reasons, of course, you can always get struck by lightning. You might have a dysrhythmia if you have ACS and you have the perfect vital signs, but you still get your dysrhythmia and die. So you cannot keep it safe for all people, and therefore it's not maybe optimal. However, there are a few studies showing that if you have a very low use, 0, 1, or 2, you are virtually indestructible and have a very good prognosis when you arrive to the ED. Now, what about finding patients or finding the needle in the haystack and monitoring? Well, again, this takes time, and repeated measurements, of course, take repeated number of time. It's costly, but it also has to be done on the shop floor. There are very few systems that can wirelessly monitor patients. So usually you have to go to the bedside and see the patient. And that's not just bad because, as I said, a quarter of all alarms were due to nurse worried. And when they measure the vital signs, they actually have to see the patient. And they might be alerted that something being wrong. So if we repeat the vital signs and use the early warning score, what happens? Now, these are data from John Kellett from Ireland, from his Canadian population he's used. And on the left-hand side, you have what he called the ABUSE, or abbreviated early warning score, a low at arrival, medium at arrival, and a high at arrival. And then you look at the in-hospital mortality and the time between measurements, and if it goes down, if it decreases, if it's unchanged, or if it increases in the early warning score. And as you can see, if you come in with a low early warning score, you have a good prognosis almost regardless of what happens. But if you come in with a medium early warning score or a high early warning score, and you're unchanged, you have the best prognosis. But for some people, it's actually dangerous to have a decreasing early warning score, and as dangerous as it is to have an increasing early warning score. And if you have a high early warning score on arrival, it's basically the same if you have an increase or decrease. And this was a surprise to me. I always thought that intuitively it would be best if it went down, but apparently not always. Now, he did this again in another population, 18,000 patients, 5 hours between the measurements. He did another early warning score called VIEWS. It's basically just a predecessor to NEWS. If it was unchanged, you had the best prognosis. But again, if it went down, you had a poor outcome. And if it went up, you of course had a poor outcome. So any change basically in early warning score is bad. And that could be another reason why we're struggling to get them to work. So what else is out there? What's the perfect dessert? I'm a big lover of dessert, and I think we should always wait for the best to the end. Well, one obstacle is that the human brain is stupid. There are limits to what we can do with the human mind. We can only see some patterns, and we can only do some not too complex mathematics in our heads. So Dana Edelson's group out of Chicago tried to use very advanced computational techniques to look at changes in early warning score and vital signs and see if they could come up with a better way of predicting outcome than the current situation. Now, the red line here is the current situation, and this is for blood pressure, respiratory rate, heart rate, and temperature. And then you look at all ways of analyzing deviations. And the current one is using spot measurements, where you measure them, then wait a while, then measure them again, and so forth. And they could actually improve the interpretation or the identification of patients if they use advanced mathematics. But it wasn't a miracle. They could improve it a little bit, but not perfectly. So we're not quite there yet. Another option is to look at interactions between vital signs. So what happens if one goes up and the other goes down? You're probably all familiar with the shock index. Now, this is heart rate divided by blood pressure. This is in 525 million Americans. And as you can see, as your shock index goes up, so does your risk of having a poor outcome. So maybe interaction is something we need to look into as well. But again, early days. So what's in the future for us? Well, we need to think out of the box. This is difficult, and they spend a lot of resources on early warning scores and identifying patients at risk. And we need to come up with something completely new. Now, one of my colleagues came up with the idea of taking a simple blood test on patients. So we took this blood test on 1,500 consecutive medical patients reporting to an emergency department. So we focused on medical patients out of necessity is what we could identify. Half were female, median age 66, 30-day mortality 2.3%, not too high, very low news, very short length of stay, very low comorbidity score, and 15% had cancer. Now, if this blood test was positive, the 30-day mortality was 4.4%. But if it was negative, and that was half the population, they only had 3 fatalities out of 800, or 0.4%. So this blood test was actually pretty good at identifying people who were not at risk. Now, I have to say, all people, this was blinded, and all were treated by the physicians and nothing had happened. So, of course, they all had the same care. Now, what was this blood test? It was D-dimer. Now, there's a lot of controversy about D-dimer, but apparently it might be a good idea because D-dimer goes up if anything basically is wrong. Now, we went through the patients and looked at the mortality and of the people who died, and it was all over the place. They had a lot of different reasons: cancer, VTEs, infections. And out of the 3 people who died with a negative D-dimer, 2 of them were admitted with terminal cancer, and the 3rd had an accident that was completely unrelated to the admission. So it's a very good marker of low risk. But again, these were all treated blinded from the D-dimer value. Now, one of the problems with D-dimer is if it's positive, then what do we do? And it's associated with infection, with cancer, with venous thromboembolic disease, heart failure, anemia, and soft tissue disease. And then Denmark did a natural experiment because they decided to measure it routinely in 8 hospitals. And we analyzed it, and it didn't increase the downstream investigations for VTE or PE. So it might be you can actually use your common sense. Another opportunity is frailty. Ken Rockwood from Canada came up with a clinical frailty scale, where you assign a frailty level from 1 to 9, when 1 is extremely fit and 9 is terminally ill with a life expectancy of less than 6 months. It takes a few minutes to do. You can easily learn it, and it's pretty accurate. And the interoperational data is convincing. Christian Mikkel from Switzerland used this in the door of the ED or the old. And if you have a low clinical frailty scale, you have a very low 30-day mortality. And as your clinical frailty scale goes up, so does your mortality. And they compared their clinical frailty scale with their triage system, the emergencies, the ESI, and they came up with actually being superior to ESI in predicting mortality. So clinical frailty scale might be a good substitute. John Kellett of Ireland also looked into mobility. And what he found was that mobility is a strong risk modifier. So if you have normal mobility and a low news, you have a very low mortality. If you are immobile and have an abnormal news, you have a very high mortality. But if you are mobile and have a high news, you have about the same prognosis as if you're immobile and have normal vital signs. So risk modifier might be a good way to do it. Mobility. So what I'm trying to tell you is that early warning scores are probably the best we have for short-term prognosis, but you should use them cautiously. I believe we should be looking at trends and dimensions. I also believe that we need to intervene early, but we don't know when to intervene because it might be too late otherwise. And we definitely should look for more sensitive, but just as specific markers. And we're looking into D-dimer, mobility, and frailty, but there could be many, many other options out there. So in conclusion, why are we using early warning scores? Well, it's not optimal to find the sick. it's pretty bad to find the well. You can sometimes use it to monitor your patients, but you can definitely always keep the bureaucrats happy. Thank you.
Okay, thank you very much, Professor BRABRAND. I've actually quite a few questions, but in the interest of time, let me ask you a couple of them. So, what do you think will actually when will we start to use artificial intelligence or machine learning in this area, where we might be having a continuously evolving scores that learns by itself?
It's a very good question, and I think it's a way that we probably need to go. There are a few studies out there. There are studies from the Kaiser Permanente in the US. There are studies from Dana Edelson where they actually are using it right now, where they integrate vital signs, they integrate clinical information from the medical records, and they integrate blood tests for that matter, and use it to identify patients. But it's still in its infancy, and I believe it's going to be quite a while before we see it in clinical use. One of the reasons is it does require quite a strong computational capacity, and we don't have that strong computers in the hospitals yet. So maybe 10 years.
Okay.
Unfortunately.
Now, another question is, where do you see the best way to use early warning scores in the emergency department? Because in the emergency department, we often have a triage process where a nurse will basically, based on protocol or based on her clinical experience, decide on the accuracy of the patient. So how do you see the early warning score fit into this process, or will that actually replaces the triage?
Yeah, well, I think it depends on what triage system you use. We triage our patient using a completely different system when they come into the department. So we use triage like anyone else, and triage based on vital signs, but also on the reason or the main complaint. But then when the patient stays with us for a while, so if we measure the vital signs, we switch to an early warning score and then just use the triage to see time to doctor. And then once they're in the unit, been seen by a doctor, we use an early warning score to then further assess how we should handle the patient. We are not like Hong Kong in any way. We're fortunate not to have that much crowding, but we have the opportunity to keep patients for up to 48 hours with us. And for a 48-hour stay, we need some way of monitoring them, and then we switch, of course, to early warning score.
Thank you very much. That's very insightful.